Have is usually regarding the starting of your exam. So every Monday you will be having something called clinical case discussions, CCD, and you will have a Wednesdays. Every Wednesdays you will have a class, and apart from it, your learning will be from the case you will be reporting to the person will be there, which will see how we are going to report. So these are your learning opportunities. Okay. Other than that, you should be knowing near-to resuscitation program, which I think all of you have registered. And also, you will be taken one class separately in this posting also. Right, Dr. Asif sir or Shafi sir, somebody will be taking on uh, the how to do resuscitation in short. Okay. Now, see, yeah, let us finish off with this thing. Note down all the doubts you have, and then you can ask me at the end of the class. And you can all in anything important you don't understand what I say, then you can ask me there itself. Any doubts you have, you can keep it at the end. Okay. To start now, if you look at it, so we have, as I told you, every Wednesdays, the posting starts with an orientation class, and then the other 3 Wednesdays or 4 Wednesdays will be different classes. And I would prefer you. You have got 3 areas to cover. What are the 3 areas? One is clinical work, patient care, which is the most important, and is most important for you also on the patient side as well as on your side. So whatever you learn from the patients will stay longer with you than whatever you read from the books. Okay, so patient care you should be the primary thing where you will be learning your in this posting. One. Second is your academics. So academics, as I told you, these are the minimum academics you'll be having. Like one is the clinical case discussion, and then every Wednesday, so every Monday will be this. Wednesdays you have the your classes, I mean, which is be only for exclusively for your postgraduates. Now, only thing is you have to now understand something. We should not be, as already explained to you, we should not be spoon fed here. Okay, it has to be an you have to read and come or study and come, and then any doubts you have, clarification which you don't understand or something, then you should ask us and we will clarify whatever you have. There are certain topics which you want to cover, we can teach, but it should never be without you reading and coming for the class. Okay, so make sure any orientation class should be without no this thing should be done. You understand? So whatever you are going to do now, whatever your class is there, you read and come. Other is no use of those classes. It will look very nice on when they take classes. As soon as it's finished, when you try to recollect, you won't be able to recollect anything. Okay, so you have to do an adult year. So first year, what is expected out of you? You should learn resuscitation properly. Okay, how do you help? What you do? What all you anticipate? How do you anticipate no problem in the delivery? How many people should go for the delivery? And all that will be learned in your first year. And regarding resuscitation, all steps of resuscitation, we'll see that. I mean, if chances are there, then you will be able to learn. Second is your line. You have to put in a lot of lines. Okay, the cannulation, IV cannulation, and sampling. So never give chance to any sisters to do that. So tell them that I would like to do IV line and IV cannulation. The sampling is there because for you to learn the primary thing which you have to learn is this. Because when you go out, if you have to impress any of your colleagues, putting the line is a thing which will really impress them. If you don't put the line, then immediate the observation will think that you are not well trained. You understand? So always think the first step in your research, one is you learn resuscitation. Second is you try to access as much as IV line and the sampling, because so that you just get to be used to how to actually prick the vein of a neonate. So once you're good in neonates, then probably the pediatric other things will be much more easier. Okay, so that's about your the learning point of it. Then other thing is you learn on the go, like lot of all the common cases. You have plenty of common cases coming here. Because when you go out also, you'll be seeing only those cases. So those cases are pertaining to that. You should read whenever baby comes. You try to make a diagnosis. You try to put the management. Even from the day one, whether you're right or wrong, don't worry about it. You can commit to whatever you like to, and finally confirm with the person who is there. So understand, can you confirm with the other person who is there, the senior residents. So your teaching primarily will come from the senior residents. Okay, the bedside teaching and other. So bedside teaching would be mainly because they are the persons who are on duty, and you will usually have time after when you are on actually duty in the evening. So that time you are supposed to go for rounds with them. Okay, not just to note down the things. You have to understand the baby's management. If you do not understand, you have to ask them why it is being done. Some of the days it may be very busy, it may not be possible, but most of the days it should be possible. Okay, so this is your basic understanding. Remember that. Okay, so this all you have to do all this. Okay, and only if you do all this, you will be doing well in your neonatal career, neonatal aspect of it, or even for that, this should become your habit in any posting you go for. Okay, so some of the this is what books do you refer? Usually, you can go for Clarity. Okay, and then the neofacts you have to use because you have to look for drug. We don't expect you to mark up the drug dosages at all. You should only look at the book when you write the dosages, because for every gestational age, for depending on the chronological age, the dosages will differ. You never try to have, because unlike pediatrics where you have got only a single dosage, here dosages will differ based on three things mainly. What are they? One, gestation age, chronological age, and the renal function status. So when you write a drug, you have to know, look into these three things before you write on a drug on a baby. Okay, so you have to remember that. Okay, and then ophthalmoscope. So this is very important. Hope all of you, do you all have ophthalmoscope? You are supposed to buy an ophthalmoscope. So please buy an ophthalmoscope and use it. And even in your, if you don't buy, no, you will never buy it. Okay, so buy it, and then you are even in pediatrics. Don't you see babies' eyes? You are supposed to see. The baby comes with seizures. You are supposed to see their eyes. You have to look for papilledema. Unless you keep looking at the eyes, you will not be able to identify that. You understand? In my possession, we are supposed to identify papilledema. Okay, more than before the ophthalmologist. So not every time they may be available, or there may not be people who are actually seeing the eyes so frequently. Do you understand? So always remember that here in newborns, you primarily you'll be looking to rule out a cataract. So you should not miss a baby with a cataract going out from this hospital, because somebody picks it up. Imagine the care we have provided to the baby. It indicates a very poor examination of the baby. The outcomes can totally change. You understand? And of course, if you are interested, you can look into the retina. But primarily thing you are going to look at is there a red reflex present or not? And how to do the red reflex, you should learn. You should not actually try to open the eyes. You are supposed to, do the oculocephalic reflex, right? So you just have to, when the baby's head, flex and extend, generally they open. You can do that, and that is the time you have to look at. I think Nasreen must have done it. You do it this year, right? So that is how you do the red reflex. So you can see the books, you can see videos, a lot of things are available. And see, or ask somebody to teach you, because everything is on. And then you need to have the inch tape before you have to measure your head circumference. Remember, length has to be measured only by infantometer. Do not use that stretching and taking a tape, measuring till hip, and then taking to the leg and like that. So never do that. So you have to use only infantometer. Infantometer is available all the time. If it's not available, then let me know. We will see what, or whoever is available, tell me. But do not measure with the tape. That's not accurate at all. Hmm? When you learn something, learn the right way to do it. Of course, stethoscope inside the ICU, every baby will have a stethoscope. You should not carry stethoscope inside. But when you are going for postnatal and other things, probably you should have your own stethoscope, and usually have the pediatric size one. You don't need to have a neonatal size. Even pediatric size will do. And then I think you all know they must be learning now. Phototherapy charts are available, so you should have in your phones, because every baby will have different phototherapy thresholds for phototherapy. Jaundice level, different thresholds are available for phototherapy. So you need to have it on your phone. There is something called, do you want to take that? Billy tool. Do you want to take that? And just type billytool.in. So you can, if you have that tool in your phone, I mean, it can be, or you can access online also. So that is called Billy tool. So if you have that Billy tool thing, then probably you just have to enter the all the gestation age, but that is only for babies more than or equal to 35 weeks. So for less than 35 weeks, you have to refer to some other chart, which is a different preterm chart for jaundice. Okay, so Billy tool, if you just type and see, you can see that. So it you just have to enter the details there. It will tell you what action must be taken based on the chart released in September 2022. So what the chart we were earlier using, what we still will not change to 2022, but that Billy tool is based on that. You can still go by it. You understood? So you just have to take plot all the enter the details there. You will get that. So that's your Billy tool. Hmm? So. So for babies who are less than 35, we usually use nice chart, but we also that is also changing. So get the help of which chart for preterm. We are going to come out with a different protocol. We will know that as this thing is going. And growth charts we have got Fenton's we use for less than 33 weeks. Okay, for babies less than 33 weeks, we use Fenton's growth chart. Okay, use sentence growth chart. More than 33 weeks, you will use something called intergrowth chart. So intergrowth is usually not there in the case sheet. Fenton is available in the case sheet. So the next new case sheet will come with the intergrowth also. Okay, so Fenton chart is there. So anything, it's less than 33 weeks, you're going to plot on Fenton chart, which is there in the existing case sheet. And then intergrowth chart, you'll use it for more than 33, but you won't be plotting on the Fenton, but you just mentioned there growth chart plotted on the intergrowth. Okay, and then in that also you should write in the, it's better that you write in bracket intergrowth. In the anthropometry, you just write in bracket which chart did you use. If it's Fenton, don't need to mention. If it's not Fenton, then we have to write intergrowth, because people should not go there and check and find it is wrong. Okay, right. So as soon as baby is delivered, the resuscitation will be. So you when you start off with your thing, you will usually start with the resuscitation. So baby will come into the unit by two ways. One is by delivering here. Second is from the OPD. Third will be from the ER. And this is a delivery points. You've got OPD, then you go to the C2 or general OPD, or in from the ER. So these are the ways they will come into the unit, into the department. So resuscitation that we have in detail what we should do, and then admission days. You will now in C3. This is the admission days, which can change depending on the new consultant who is joining, or we will keep changing. So Monday, Friday, Sunday will be my admission days as Prakash. At Wednesday and Saturday will be Uma Maheshwari, and Tuesday will be Dr. Shafi, and Thursday will be Dr. Ravindra. Okay, remember that, and the initial few days you keep ask the nurses, they will know, and then put the admission whom you should admit under. After that, you will know very well. After probably a few weeks afterwards, you will know it by heart. Okay, and then in G3 said all will come under, because that's only one unit in on the G block side, because medical college hospital will come under only the HOD. Okay. Now, once you, as I told you, initial listing will come from the delivery points. There are two delivery points. One is the labor room. Second one is the operation theatre. So, I think operation theatre you have to get oriented to the operation theatres here. Okay, so you should go along with somebody. Otherwise, even now I don't understand the A6 OT orientation. Okay, so now you're going for call. When they call you, you have to identify why they have called you. Okay, and then identify is this a call for you to come, because sometimes there's two types of call comes. One is the delivery call, that means that the baby is going to be delivered. First, other one is the information call. So don't call it as first call, second call, don't confuse. When they call you, just ask them, is it a delivery call, is it an information call? If they say it's an information call, it means that they will give you another call before delivery. Okay, so clearly ask them, are you giving me information, or is it a delivery call where I have to come? So whenever they give a call, you are expected to reach there within 15 minutes. Okay, that is the time limit. So you should reach there within 15 minutes of your call. Okay, so you should never go into the this thing. So the next is when you are going for a call, how many people are required to attend the call? Okay, because there are different categories will recommend different depending on the risk factor in the mother, in the perinatal risk factors. Then based on that you have to. So if they say any risk factor, then you have to go with two people. One will be senior resident or faculty, and one will be among the postgraduates. Okay, so if there is a risk factor, like risk factor means anything, diabetes, hypertension, like anything, there's additional factor which can potentially cause problems to the delivered baby. Okay, say for example, if you take diabetes mellitus, so you'll have, a big baby. So they can have shoulder dystocia, asphyxia, and things like that. So whenever you are having an risk factor which can potentially affect the delivery, so whenever the call comes, mostly will be coming to them, or even if you take the call, so questions you need to ask is what are the risk factors are there in the mother. So once you ask that, then you actually go and discuss with the senior residents until you finish your 2 years of your posting, and then until probably then you can decide independently. But anyway, you have to discuss with the senior residents that this is the delivery call they give, and then they will decide whether one person should come, two-person should come will be decided by us and not by the obstetric team. So don't ask obstetric team, do you want an assistant or do you want another person to come? Understood? So how many people should go for delivery should be from our side and not from their side. Understood? Okay. So the next is this side, all the calls will be covered by another person. Along with postgraduate, this side all the calls will be covered by another person because this is a corporate side, so it will go as per the corporate rules. So you are paid for the resuscitation, so you cannot go alone for resuscitation because then there should be somebody at the level of senior resident who should be coming. Whereas the other side, if there is no risk factor at all, you will only be going. Okay, and if there is a risk factor, then you have to take the other person along. Okay, the other person should be senior to you in the sense it should be at the level of senior resident or a faculty. Okay, right. So this is what has been there. So what I told you, so here is calls. So of course for twins again you should be prepared in such a way that two team goes is not one person cannot manage twin deliveries. So mostly twin deliveries will be high risk, so at least four people should try to go. Okay, and then yeah, of course, the check vitamin K, all the drugs, not only for vitamin K, all the drugs before administration, you check is this the drug because some of the while will look like Alexi. We have an experience of giving metformin to one baby because metformin and vitamin K looks alike. So there's something called look-alike, sound-alike, which you learn as you go on. So look-alike drugs are more dangerous because many of them you look like that. Oh, that's vitamin. We won't because the letters are very small. You won't have the patience to look into it. But remember, as doctors, you should look into the drug name and the expiry date for any drug you are going to be giving. Okay, without that, do not give that. Right? So you need to discuss with them to decide who will be attending the delivery. Okay. So when you're going for a call, so what all things you will check. So check the resuscitation kit, and please remember, the resuscitation kit is always checked by the nurses in the morning. But before going, also you have a check of the important things, which is there or not, is it working or not. Okay, so you cannot have a not working bag. Bag if it is not working, it will not. The whole resuscitation will be spoiled and the baby will die. So remember that even a small step, any mistake you do, the problem is this does not happen. So suppose you take 100 deliveries, you may require this only in about 5 or 6 deliveries. Okay, so when if you check for 100, you will prevent this five. Otherwise, which exactly the time you don't check, the bag will fail. It does not. Don't think it does not happen. It has happened here, and we have to use adult bag to resuscitate, and somehow we have resuscitated the baby. But that is not the way you should be doing. Okay, for every delivery, when you're going it, you have to check. There are certain things you should check. What are they? Above bag, laryngoscope, ET tubes are available. Okay, and then the other, the other source you check there like oxygen source and suction sources. Okay, these are the basic things you should not miss at all. Okay, so bag will be what all things you check in bag. You check the ambu bag, two masks at least, two masks, that is one and zero and one size. Okay, along with the reservoir and an oxygen tube. Okay, so all these things is very important when you go for a labor contract. Okay, so these are things which you have to look into: stethoscope, laryngoscope, pinch tape, and for preterm resuscitation, blender is must. Less than 35 weeks, all babies are blender, and you have to have a plastic wrap that's less than 32 weeks. So what you do is there's something called zipper bag. So what happens, the less than 32 weeks, they tend to lose temperature very fast to the environment because their skin is not mature, right? So one of the important things you should manage in your newborn babies is temperature. You understand? Because temperature can change the outcome. You understand? Temperature will totally change the outcome. So you have to be very, very careful in doing the, checking if the baby is having normal temperature or not. That's why we immediately, you want to, if you look at the resuscitation steps also, the initial thing is given importance for warming the baby first. And then only you go for further steps of resuscitation. You understand? So any baby you find the less than 32 weeks, you have to carry a zipper bag or plastic wrap which will be given. Okay, so that needs to be, as the baby is born, you put into it. And those resuscitation you will learn as you go. And then you use T-piece resuscitator. That's in our unit is called neopuff. Okay, so you need to carry that and the attachments of it. Okay, neopuff alone will not work. You need to attach oxygen source to it and the tubing for it. Okay, that you learn. So neopuff along with its accessories. In daytime, you will whenever there is a need for neopuff for high risk deliveries, there's a called Dr. Sonia. Sonia is there. She is a respiratory therapist. She will accompany with you. And you can learn a lot of things from the respiratory therapist. A lot of respiratory managements are done by her. So you go along with her and learn, things which are necessary for your practice. And then documentation, there's something called resuscitation form. And now what you do as soon as the baby is delivered, you do the weight check there. So you need to get trained how to do the weight check. Okay, don't think it is simple. You just have to remove all the dress, put the baby there, and wait for the baby to, settle down. And it's very important because the baby's, further weight loss or other things is important for our future managements. A lot of times when they do the wrong birth weight check, you have admitted the baby unnecessarily and got into trouble. So you understand. So that's about your this thing, and then finally you write. Now in this case sheet, I'm not sure whether he's got it. So we will see how we do once the case sheet comes. So you have to fill in that the forms which is there, and we will see how you fill up all the forms. Then all the babies, if the baby is cry, they go for something called delayed cord clamp, which is an important step in the management. All the babies should go for delayed cord clamp. The delayed cord clamping is you delay the clamping for 1 minute. If it is even a cesarean section or is it a normal delivery. Okay, so babies, as soon as babies delivered in normal delivery, we expect them to put on the skin to skin care. Okay, and then you do the drying and all that, and then you wait till the thing to be clamped. I hope you are doing that. All babies will be delivered onto the mother's abdomen. Okay, and then in normal deliveries. Cesarean section we don't do that, but in normal deliveries we put them onto mother's abdomen. If the baby is crying, you do on many steps on the mother's abdomen itself, and you delay the cord clamp. And we do zero separation in the G block side. Okay, so G block side we don't separate the baby and mother for 1 hour. Whatever is being done will be done on the mother's abdomen itself. Examining the baby, giving it vitamin K, everything will be done in the mother's abdomen. We'll be implementing that in the main block zone in this medical center also. So we are trying to work out there, and then we will try to do that the same practice this time. Okay, so the G block, if baby is delivered, will be on mother's abdomen for 1 hour. The baby is otherwise fine. Okay, no risk factors. Not your term baby, more than 35 weeks and doing well, will be on the mother's abdomen, and it will be all the things will be done on the mother's abdomen. Okay, so if you're not done, also you're supposed to tell her that is the unit protocol. Not done, let us know. Okay, so this is about your management. So whenever the Baby is vigorous, and before it is better that you before it's you plan are you going to delay or not, and tell the obstetrician should we delay the cord clamping or not. Okay, so all vigorous baby at least 1 to 3 minutes. Yeah, and one more thing which people don't forget to do is starting the Apgar time. Otherwise, you will not know what time is this. So as soon as baby is completely delivered, you have to switch on the Apgar time. Okay, there will be. Uh, yeah, okay. So if you are going to have the Apgar timer switched on, as soon as baby is delivered. Okay, remember that. As soon as the Apgar this thing is there is an Apgar timer in your warmer. As soon as you see that, you switch on the Apgar timer. That's very very important, and people forget to do it because at 3 minutes the saturation is target is different compared to a 5 minute. Unless you switch on the timer, how will you know what minute are you resuscitating the baby? Okay, so these are some more things which you should learn and you should practice. Okay, so clamp and other. Okay, now after delivery we usually ask for placental examination. There are certain indications for placental examination. So anything related to infection or IUGR, we generally send for placental examination, like PPRing, unexplained IUGR, or there's Doppler changes, hydrops baby, false smelling like a metal. These are all indications for indicators of chorioamnionitis. False smelling like a maternal fever, tachycardia, and leukocytosis. These is all maternal leukocytosis. Okay, so if you have this, then that means there is a possibility of this thing chorioamnionitis. Mostly for this, the last indication, they will definitely the obstetrician itself will send it. But just I'm just telling you. But other things you have to ask them to send. Otherwise, they will not send. Okay, for all preterm deliveries, especially less than 32 weeks or so, in we have to counsel them because the parents have to anticipate the stay, the cost, and other things, right? So for all preterm delivery, we'll have counseling. So the preterm counseling will be done by trainee and the postgrad, in the sense SR and yourself. So you also have to learn what all should you be telling, explaining what are the complications and other things. Screen record. Okay, so what all things are going there. Okay, so you are going to now going to have a senior resident or a faculty will come with you, and you have to know what all they will discuss in a preterm. Then you will learn what are the competencies. Anything you do in this thing is part of your training. Okay, it's not as an job for you. I mean, we are not trying to put some work on you, but everything has got a training component in it. Okay, if you just go there, generally you learn what are the complications you have to explain. You go and you pass out also, you will be expecting. So all officers will ask, what is the outcome of preterm? Right? So anybody go out, they will ask you. Right? So you should know how to explain and anybody who comes. Okay, so you'll have to counsel the mother and the attenders, and then you usually counsel for RDS, need for surfactant. Your why surfactant is given specific dose has got lot of costs. Right? It's about 10 to 15,000 a dose. So now we'll have to explain to them there's a need for that because they have to be prepared. Nobody will carry that much of money, right? So we'll have to tell them for them to get prepared that these are the things expected. So what is the need for ventilatory support, incubator care, what is incubator and feeding issues. So a lot of things which these are all preterm related complications. The duration of stay is usually at around the 34 weeks they will have to stay. So around 35 weeks, we usually say from EDD it is 2 to 3 weeks prior they will get discharged from EDD. And the expected date of delivery 2 to 3 weeks prior they will get discharged. You have to definitely explain the cost whether it is G block or main block. Okay. So admission and registration form, I think we will be how you'll be there is a case which I'll explain to you after this. But to fill in the registration form, and also there is something called database entry there. There is something which you will be entering, something which will be the SR will be entering. Okay, babies who are coming into the NICU, you have to go into the database and enter. Okay, that's a different from what you saw as handover sheet. I'll explain to you that. Okay, so no case sheets. We will have this case sheet later. Right. So other things are all mostly general things. Like whenever you're writing a drug, remember that you should write only generic name in capital letters, and you have to write your name and signature. Okay, so that is required in all the whenever you are writing a drug. And when you're stopping it, then from you just put the strike from the last dose received. You just put one strike mark and then write stop or date and time. Okay, so these are things you need to remember. Right. So now the most important part is this is an the NICU is always has a lot of work for you. So now it is important that you keep yourself stress free, and you know how to be that. It is only ways if you work as a team only you'll be able to do that. Okay, and not only work as a team among yourself, also with the senior residents. You understand? So always see to that you are having your own. Never have an order for any work to be done. Every work is the responsibility of every person. Okay, if something is there, if you are three of you are there, one person finishes of the work, and automatically that person should go and check if the other person also have finished. There is no demarcation of work. It is only the responsibility is given to one person. You understand? The postnatal is given to Rachana, so it is responsibility goes, but doesn't mean that she is only have to do all the work there. So if you finish your work in ICU, then you go to work the postnatal. If your postnatal work is over, then you get into the ICU. Okay, then only you will not have that pressure of looking at what work. But the work will be equally balanced, and all of you will be able to finish off the work earlier. Okay, so never have this is how I work or that work. No, ask work like in your family. Would you like how do you work in your family? It's just work like that. So Rota, like for each piece, like you will be doing because I got three people. Every day will be one person will be on duty. The post duty day, you can leave after you finish your work. If you have already if you have done the previous night all the work which is to be done next day, you will be able to leave earlier. Like preparing your discharge summaries, keeping all the investigations, what all needs to be collected, let to be sent, all that if you completed, then it will be easier for you to leave. Okay, we don't want you to stay more than the time you are supposed to stay, but at the same time, we don't want you to leave before you finish the work also. Okay, so how do you do that? The previous night itself, you plan everything, and the night duty you have time to do. Just keep finishing off every work. And remember, some of the times the work becomes heavier, a lot of work is there. Then the senior resident may ask, probably he will feel a lot of things are not finished. But then you will have to explain to him because most of the times they are misunderstanding is what commonly happens. Okay, so never and nobody will think there's only a misunderstanding of whether things are because sometimes when they say the work is not done, they'll check why is it being not done. So another don't get offended by any of those remarks. Take it lightly and then tell them so this is what I was doing and then you'll be finishing things as it goes on. And then Paul, that is the time you learn which to give priority. Whether the priority should be given for this work or the other work. You understand? So everything has got a learning component in it. So, right. So you have to write you are primarily responsible for the nursery babies which are without any respiratory support and do not require too much of intensive care. The workload is has been divided so that everybody sees every baby appropriately so that the care of the baby is not compromised. Okay, so you have to look at the nursery babies and you make notes only for the nursery babies in the morning. You understand very clear, and even if the SR asks you to make notes, you tell them that you are advised to do this, and then I'll ask SR to speak to the faculty. How do you silently send a message that you don't want to on a screen recording? So if you are going to have the recording, sorry, you are going to have the SR, whoever is there, and then if there's any deviation of this protocol, then you just have to silently tell me that this is happening. Okay, then we will confidentially deal with it. But remember that your work will be like you're going to start the nursery babies in the morning. Usually, the post duty person can see all the babies because they'll have a lot of time. So around 8:30, we will start the handover uh, process. So you are expected to come by around 7:45 here. The new person who is taking over. You take about 20 minutes for you to just to say the nursery babies mostly already you would have seen. Only the new admissions you may have to hand over in detail. So you have to learn how to do it. There is a pattern for handover. So it will be taught to you. It's called S bar, S bar or S bar. Identification, situation, then you have to say background, assessment and recommendation. Okay. So these are the things you may have to look for and do it. Okay. So and remember that you need to, when you're doing the postnatal round, most important aspect, there are certain things you need to do on day one. What are you supposed to do on day two? What are you supposed to do? Okay, on day one, when you are going in, you need to assess the baby. Has the baby started to breastfeed or not? And then in the first 24 hours, has the baby passed urine and motion? That these three things should never be missed. Okay, and then you have to look for other things also, like all pulses. Because there are certain things which in neonates alone, they look absolutely normal at birth. Okay, and then they have all the problems manifested in the next 24 or the next week also. Okay, so see, you have to look at that properly. As I already told you, you have to look for red reflex, and you have to look for weight loss. Okay, so whatever weight is being there, you have to calculate the weight loss. Each day, I mean every day difference should not exceed 5%, and the overall cumulative should not exceed 10%. Okay, remember that. So if it is exceed, then you should, it's a red flag sign. So you just have to open up and say or highlight it to the consultant who is coming for rounds. Okay, so that they take actions appropriately, and so you also learn how is it. And then weight loss is normal in all the neonates in the first week of life. Okay, some physiologic things you have to learn, so that all you learn in your postnatal rounds. Okay, as you go on. So everything what you do, you should be there. We initially had something called transcutaneous bilirubinometer. It's called Billy check, but we did not have it now. It will be available because it got repaired and they're trying to get a new one. Until then, we will be sending bilirubin. Remember, for all preterm babies, we will send the bilirubin at 48 hours of life. Okay, so always plan that and keep, and then confirm with the consultant and send it. Okay, all preterm babies at 48 hours of life. Okay, for other babies, we'll usually look if there is jaundice and then send. Now, G block side, sometimes they maybe electively will be sending at 48 hours because we may hear the intensity of rounds may not be as this thing as this side because of the uh, manpower availability. Right? So, another we usually send on that side, we send this thing, and I want you to actually assess the jaundice and have a number in your mind and then send it and correlate with it. Okay, so then only your this thing will change. But they also remember some of the times our clinical assessment may not always correlate with your serum bilirubin. So how will you learn all this? Only when you keep practicing on the baby, then only you will know that. So remember all everywhere you look into these things. Okay. Now let us come back to this. Okay. Now postnatal rounds. I think morning we will be there are two main block and G block are done differently. So here in the medical center, we this is morning they will start rounds by around 9:30, and then you have to finish every discharge summary everything by 12. Just 12:30 because they have to send it for especially for insurance patients. So it is better that you keep the previous day itself everything ready. Probably the things which you have to enter is maybe the weight loss and your jaundice level. So mostly this is the things which you may have to enter. Other things, most of them may not be there in the postnatal ward or routinely term well babies may not need anything more than this. Okay, so Nala, as nurses actually previously what they used to do as soon as baby is delivered, they have time they'll dictate discharge summary at the time of birth itself. So most of the times will not change. Okay, so at the time of birth they will have the checklist. Okay, so what are things you will do at the time of discharge? So you have to do something called panel 1, panel 2. That's a screening test. Panel 1 will cover TSH and 17 OHP. That is to diagnose this CAH, congenital adrenal hyperplasia. And then panel 2 consists of inborn error of metabolism to diagnose metabolic disorders. Okay, so these are two panels done, and usually it is done after 24 hours, preferably after 48 hours. If they're going to stay for 2 days, then you wait till 48 hours. If they're not going to stay or they're going to get discharged at 24 hours, then within 24 hours also should be done. It can be done. Not should not be done within 24 hours. Anytime after 24 hours you can do. And most of the patients and most all will discharge only after 24 hours. Okay, remember that. And if you're not done by any chance, like Sunday, you don't have filter paper or things like that, please remember to write down that this is not done. It has to be done on follow up. Okay, so panel one, panel two, hearing test and pulse oximetry test. So you know what is that? So there are we got four. These are the screening tests you do. What are they? Panel one, panel two, and then you got hearing test. So hearing test you have to order. They will come and do it by themselves. And then fourth one is your pulse oximetry test. So pulse oximetry test you have to read. So what do you call that as pulse oximetry screening test? They will put the other person will do, and they will usually write the values. I think it will be like this. Yeah, so they'll write like this. So they'll check the right upper limb and then they'll also check the lower limb. Okay, so they'll write it. There are interpretation that which you will have to learn as you go on. Okay, so that interpretation you will have to look at it. Okay, okay, that's about your postnatal rounds, and then vaccination. Another one is immunization you need to take. So immunization is done on Monday, Wednesday, and Friday. Because BCG they don't open every day, so they will open only the alternate day. So 3 times a week it will be given. So Monday, Wednesday, and Friday. Okay, so you have to plan it. So whether the other side they give it on Tuesday, Thursday, and Saturday on the G blocks. So look at it. These protocols can change because this is done by the pediatric department and not by neonatology department. So now if the protocol changes, you have to change accordingly. At present, the protocol is Monday, Wednesday, Friday, BCG will be given along with the other vaccine, and then on the other side it will be Tuesday, Thursday, and Saturday. But remember that these immunization things will keep changing. Keep up to date of your vaccination protocols. Because now you're going to change a lot of things. You're going trying to give hepatitis B at birth itself. So you're trying to process finding out the logistics to do it. Okay, and then in yeah, preterm baby, suppose baby is getting more. I mean, looking at extreme preterm, those who have been received respiratory support and all that, this are summary will be prepared. Either they handwrite and give it to you to dictate, or the things they will tell you what to do and you will dictate. But you will not be preparing the research summary. But why we want you to dictate is because then you will know each baby what all problems happened in every baby and how was it managed. So it's a passive learning for you. Okay, so they will writing you so that when you dictate, you will know that these are the things which has been done. Do you understand? So, okay, so you hope you understood that. So these are preterm babies will be there. So primarily managed by the SARS when they come, but then you will help them so that you also do procedures. So only when you get more involved in their work, then they will give opportunities for you. They will also look things to say what all will suit your for you to learn, like every umbilical lines, any lines of the input. So you'll be getting chances as you go on. So you have to learn how to put an umbilical line. Okay, so umbilical venous line especially after line is okay. Umbilical venous line, yeah, basically. Okay, so you understood. So you are, when the baby is going to get, we have got KMC ward, we've got ICU inside, and we've got KMC ward. Generally, around 32 weeks, we'll be shifting the babies. They're not on any respiratory support or did not have any events in the previous 1 week. So when they are getting shifted, then the discharge summary should be prepared by the senior residents, and then you have to probably have to dictate, and then baby gets shifted there. If it's not ready, then probably you have to remind them to do that. Do it. But you are not going to prepare the discharge summary from the case sheet. Remember that. You are not going to do that. Your role is only to, if they have to, probably write everything and give it to you, you can dictate. Understand? So, but you are not going to primarily do everything and get it checked to by the SRs. You understand my point? The SR will take care of all ICU babies. Okay, those who required intensive care. Whoever was there in here, if you look at it, will be like B and C baby. Rather that side it will be A and B. So very short respiratory support, TTN and things like that, you can fill it out. Babies who are having a long summary, especially stayed for more than 5 days, then it will be the work of the senior residents to do the discharge summary. But you should also get involved in it by dictating it so that you know what exactly was done for every baby. You understand? Okay. Yes, and then other thing which you'll have to look at is the hip examination, which you will learn and then for you may have to do for all the babies. Okay, so in general, so how do you do the follow-up? Okay, so babies who are well baby, in general, when they are going, this is all rule of thumb. So they're going on day one, they come back in one day. If they're going in day two, they come back after 48 hours. If they are, that's a rule till 5 days. They're going beyond 5 days, they can come back after a week if everything is fine for the baby. The weight loss is within permissible limits and baby is otherwise fine, feeding well, mother is confident. If all these things are there, then you can ask them to come. This come after week. Understood? Rule of thumb. If even if you can yourself decide. And what I want you to do is in the discharge planning, you should write that the plan for discharge. You should write that what is the time of discharge, so that you learn what to do and you try to understand how do you plan the discharge, because these are the things you may be seeing in your practice. Okay, and it's very important because if you suppose the baby is discharged on day one or day two, and you call them after 7 to 10 days, the baby would have gone through an very high jaundice, may get admitted with chronic. And if you have a baby with chronic stress, then no point to be doing a degree of MD pediatrics. Remember that. Understand? Not one baby should develop chronic stress under your care. A baby delivered with you, you have to be strict in monitoring the baby's outcome. You understand? So if they are the primary thing you're asking them to come is for jaundice, but other things also may be there like feeding issues and other things also will be there when they go home. Because they hear everything is supported for the mother, and when they go home, I don't know how far mother is being supported. Okay, and breastfeeding. You should read thoroughly about breastfeeding, how to counsel for breastfeeding, and help the mother in breastfeeding. If one thing if you are doing in your practice, if you send the baby on breastfeeding home, is the best thing you can do for a baby. Okay, among the factors if you take, what all things you can change in a baby's life is establishing breastfeeding at the time of discharge and not introducing any sort of milk, whether it is formula milk or the other milk. That's a regular milk. So remember, this is one of the things you should remember and drill into your mind that I'm not going to discharge any mother without not on breastfeeding. Okay, I'm talking about term well babies. Okay, this I already explained to you. Okay, right. So discharge summaries again. So when you are doing it, so you got the photocopies of the growth chart and preterm checklist should be given to the mothers. When they are going for when they're coming back for checkup, you will be plotting on those growth charts. Okay, so growth chart and preterm checklist should be given to the parents, and they could take a xerox copy. You should not, the one should be with the case sheet and one xerox should be given. If you tell Satish, he will take a xerox and give it to you. Okay, that should be attached to the discharge summary. Okay, so preterm has got the long checklist. Okay, so everything should be there in your discharge summary. Okay, that you should go through. A lot of things like ROP is there. Okay, you have to look for hernias is there, and other plenty of checklist there which you have to go through everything, and then accordingly you plan your discharge. Okay, right. So ultrasound hip at present, what we are doing is we are doing ultrasound hip for any baby who's got a breech delivery. Or on examination, in a hip examination, you find that there is an pluck you would have read earlier. What is the hip examination? If you are suspecting a CDA, then you do an ultrasound screen. And remember, for both radiologists should be informed at 8 o'clock in the morning for them to plan there, but they have plenty of other scans to be done. So you have to book a prior appointment. So remember that. And then for every preterm baby less than 32 weeks and less than 1.5 kgs, you definitely need something called early stimulation program. Called early stimulation program for which Dr. Prabha should be involved. Okay, it's called early stimulation program, called ESP we call them as. That is usually introduced at around 3 weeks of life when the baby is stable. Okay, so those things, all the things should get incorporated. And remember, there if you got different subspecialties, always ask whom we should refer. You understand? Because there are some specific subspecialty person. Some of these are adult who are also doing pediatric. Like for example, if you take hematology or neurology, you got a dedicated pediatric nephrology also. You got a dedicated pediatric person to do it. They won't do. They won't see adult. They are pediatricians who subspecialize in this. Okay, they are hematology, neurology, cardiology, okay, and then nephrology, endocrinology. So all these are there who are doing your subspecialties. Now and pediatric surgery and urology, you need to know the difference. So anything related to exogenitally and urological problems will be directed to pediatric urologist, who is Dr. Ramesh Babu. All other problem pediatric surgery goes to the pediatric surgeon. Okay. Now there are other things where we don't have like ENT. We don't have a specialist pediatrics. So we call the ENT people, ENT team. So usually Dr. Prasanna comes in there. So those teams, and for orthopedics again, you don't have a specialized orthopedic surgeon, but some of the adults who have got special interest in pediatrics. That is your Dr. Gopinath Nair. You understand? For hand alone, we have got a separate team called hand surgery. So before you give a referral, please ask the SR whom should you are going to give the referral. Don't send a card, telling that to orthopedic or to the department as you do in pediatrics. So ask them who is going to specifically which consultant you will be sending the card for both sides. Understood? Please don't make a mistake. If they just say, give nephrology opinion, it means it is to Dr. Sangeeta. You understand? If you say cardiology opinion, it means it is only to Dr. Jagaraj. You understand? It's like that. Okay, so these are things you'll be carrying. A TCP machine at present it is not there. And remember, the rounds book is a very good way of systematically doing things. Okay, you can have all the what all you need to do. There's a way to do it. Learn it. Okay, so you just have to put the names of all the postnatal things and write down the work needs to be done. So usually we put a square with a diagonal in it, and upper part of it is that we have already done. The lower part is after you get the the this thing there. You would have seen in that book, yeah? So those things you can learn. You just put a square, right? You put a square, and then put the once you put the square is as soon as it is ordered. Suppose we ordered an ABG, na? You write ABG against that baby and put a box like this with the diagonal. Okay, and then once suppose you have sent the ABG, then it will be you mark it there. So once you collect the report, then you mark it here. You mark the lower box. So this will be another way of this is one other way, but if you all of you are having and uniformly follow one way, do not have each person should not have each different way. This is the our recommended way of doing it. So what will happen at the end of the day when you're handing over, you open the book, you open the book and then you open the book and then you just have to hand over. These are the things which has been done. These are the things you need to collect the report. Okay, those things which has been done, you don't have to bother. Those are not done, you have to handle. So unless you have something like that, you will not know. So you have to have the rounds book. You have to have the separate note for postnatal, separate books for rounds in the IC. So both has to be maintained. So in the evening you take over and remember allocate yourself. About three of you are here. So one will do ICU exclusively, one will do postnatal. Other person will be a floater because one person will be off, that person will come and go. Right? After 10 days you rotate. Okay, so rotate and then have. But when you are a senior person, in the G block side, the senior person will be only in the ICU. The senior most will be only in the ICU. Other persons will have postnatal and they will take call. The same thing, one person will be a floater. Okay, so whoever is not there, then the floater will come. Understood? Why is this is done? Because you will have a follow up of this thing correctly and you will be able to see, about the baby's previous day, so you will be able to do the work correctly. You understand? It save your time. Understand? So you should have the allocation of your work in such a way that you are sticking to one area so that you are having a complete follow up of those variables. Okay, and then so suppose if you are doing the post after your duty, you see to that as far as possible to இது பண்றேன், record பண்ணிட்டு. As far as possible to what you need to do, as far as possible you stay for the rounds, learn what is in the rounds. Okay, see to that you finish your work before that and be in the rounds for you to learn a lot. Okay, only in your post duty you will know what all things you have done. Is it done correctly or not done correctly? So that is one of the best learning you can have in your post. Okay, so see to that you have joined, and even if some of the work can be done later on, just do it later on. You for but the post duty that they're looking at the summary of the post duty before that, do not do it. Okay, so we'll usually take over the day after. Okay, the next day we'll morning will be taking over on almost all days, right? So this is already told you, like you finish, and also please have your breakfast. No, you are not doing your training appropriately if you're not having your breakfast on time. Okay, so we breakfast or any further lunch, dinner. So I don't think anybody will stop you from going for breakfast. But you should have a reasonable time for your breakfast. If about 15-20 minutes, you should be done. Okay, whichever you have grab, or either you get it from getting from home, they will supply it. If not, you buy from the order from the canteen and have. But really, we cannot spare 1 hour or 40 minutes for your this thing. So food the time would be a 15 minutes. You should go have and come back, whichever way you can do it. But you should not be starving to work. There are two problems because of it. One, you will feel very exhausted. Second is you will make mistakes. So if you are not eating on time and working, it is unprofessional. Remember that. Okay, it is unprofessional. Don't think that you don't feel guilty or bad. The baby is sick. Should I go and have my food and all that? No. You understand? You should have your food on time, however sick the baby is. Okay, if you are three of you are there, you see to that each one of you relieving each other to go for your food. Okay, and also to take time if all of you are here, night time you can come and meet in the canteen and meet and eat together and things like that can be done. Or you get food to the unit and have food in the unit together. So these are some of the ways you can de-stress yourself. Because working in an ICU is always stressful. You should learn how to de-stress yourself. You understand? But this when you go outside also will be the same. Even in pediatrics will be the same when you're going outside and going to work in any place. You understand? So another learn how to de-stress yourself. Learn to work more at the same time without much of your stress. Okay, so de-stressing one of the ways is you have meet more people, keep talking to more people, get the nurses, talk to them, give them some of the things, and then these are the ways you can have nice time. You will not feel the burden of working. Okay, right? So at night time there is something called you have to go to OPD. Remember G block OPD. You have to reach there by 10:30 to 11. Okay, so to one among you have to go to G block OPD. Okay, between 10:30 to 11. That is on the other side. If you are posted on the G block side, the C2 side you should go for the clinic at 1 o'clock. Now the importance is this is one of the important thing you have to learn. What you should do when the baby comes on your OPD, because this is what you will be seeing. Right? The baby will come on OPD basis, you will see that baby. No, you have to plan. It is not. Don't think that well babies do not have problems. They will also have a lot of problems. At least 50% of the babies will have problems on their follow-up. They will have excessive weight loss. They will have jaundice. Okay? They can develop a murmur. Like a lot of things can happen. So you have to know how to identify all that. So that's why you need to be posted in this time. And then your night reporting. Please try to report you all whoever is in the night duty will have to report the concerned person. Ask the SR whom you should be reporting initially for you to understand. Okay, so you have to report to the concerned person by 8:30 to 9. Some of the time the SR will tell you that these are the concerns they have to tell to the consultant appropriately. Otherwise, they do not have any concerns. You have to report. Before reporting, you just do a rounds along with the SR or whoever is on duty and try to understand and see what you should be reporting. The reporting has got a sequence, right? So reporting should always go in one sequence. But first to say the situation, okay, situation especially for a baby who's what is the present situation of the baby, and then talk about the, what is the respiratory status. You start from respiratory, respiratory, cardiac, and then you go to the other systems. Okay, never start with baby has got weight loss or so much. Okay, talk so and so baby admitted for weight loss who is cardiorespiratory wise they are stable. Okay, they are stable cardiorespiratory wise. The issue which baby got admitted is for this. And whenever you're calling and asking for some clarification, first tell why are you calling for. Never start with this is a baby who's a term 37 weaker and all that. I will be looking at what are you trying to, what are you asking for. So suppose just imagine I'm going to ask this baby whether this baby can be admitted into G block or main block. Because again they are not affordable, so you have a confusion whether this baby can be admitted. What the first thing you say is, so I would like to know whether this baby can be admitted in main block or G block. Then you say, then what will happen when you say I will keep analyzing to answer your question. Okay, remember this is the way you should ask for anything. Never say start here we have a baby who has got and then you will ask, so this is what I have. But then that will have no relevance to what you said. You understand? So know how to communicate. This is one of the important things which is lacking even now with many people. Even in, many adult who have gone out, passed out also, they really struggle with this. I think you should learn how to communicate. The communication is important thing. I think there are a lot of there in your YouTube, a lot of things are there. You think that we'll always think we know how to communicate, but and you should also, if you know, probably you learn from. I mean, you can see you are right or not. Always you learn from the things, and we will be teaching you also. But you should learn communication very well. Okay, so these are some of the reporting. When you start, you just start with the problem. Babies, your reporting can be done in two ways. One, you can go topographically like see you finish all and then come, or you can go by the babies with the maximum problem. The advantage of going with the maximum problem is your attention span will be good initially. As it goes down, your attention span will drop. You understand? So now you start whichever babies you really want to know, or some of the babies you will be interested to know what to do, right? So you can present that first. You understand? So whenever you are doing the thing initially, you always present the thing of interest for you and then for the baby, and then you can do it for other babies uniform. You understand? So never start with the starting with the blind term. Start with the problem, then you tell the situation, then talk about the baby and other things. Okay. Right. So these are some of the issues as you go on, you will learn. So as I already told you, phototherapy you will be looking at different charts which you will learn, and then weight loss of more than 15% is very very significant. Okay, so more than 10% itself will start. You'll have an alarm, and then from 12.5% you have to look whether the baby needs admission or not. 15% is then I think to get the baby admitted. You understand? More than 15%, I do not want any baby sent home. Okay, so some other times in the rounds you may miss it because you're looking at the weight loss and all that. So when you prepare discharge summary also, you can look at it. At that time, if you identify also, you tell the consultant that this baby has lost more than 15%, or weight they would not have checked at the time of doing the rounds. Okay, so remember more than 15% is a red flags. Okay, you are going to get them admitted. Okay, and then right. So like I think all this or then your protocol. I think you have to read the protocol. Okay, a baby comes with hypoglycemia. You need to know what is hypoglycemia, what level is it. So all will change based on their risk factors and the time of life. Okay, so everything you will have to keep alert. But remember, the first 4 hours is less than 25. First 24 hours is 35. 4 to 24 hours. Okay, and then this is less than that only you call it as hypoglycemia. After that it is 45. Okay, anything below 45 is hypoglycemia. And any call comes from the postnatal ward, please go and have a look at the baby before you advise anything. So do not do this on the phone because they, especially if they complain baby is not feeding or crying excessively. Any worries they have, immediately go and attend to the baby. Okay, don't think that most of the out of 100 times you may have a problem only about 5 or 6 times. But then you should not think that because we have identified a baby who was just before death. We have identified because the parents complained.